Have you ever marveled at how, I don't know, a simple paper cut just vanishes without a trace? Or maybe how a broken bone, like against all odds, mends itself back into a solid structure? We all experience injury, right? But beneath the surface, your body is engaged in this incredibly complex, orchestrated symphony every single time it takes a hit. Today, we're embarking on a deep dive into healing, regeneration, and repair. And this isn't just about things getting better, it's about the really intricate biological processes your body uses to mend itself. And for you, our curious listener, especially if you're sort of navigating the fascinating world of medicine for the first time, we want to cut through the complexity. Our mission, really, is to give you a shortcut to being well-informed. We'll use some memorable metaphors, maybe some clever anchors, and a helpful acronym to make these vital concepts stick. Joining me, ready to guide us through this incredible material, is our expert.
Great to be here. It's a fascinating topic.
Definitely. So, have you ever wondered what really goes on beneath the surface when your body repairs itself? And crucially, what determines if it comes back good as new, or if you're left with a lasting mark, like a scar? Keep that question in mind, okay? Because we're going to dive deep into exactly that. Okay, let's unpack this then. Before we talk about healing, we need to understand what we're healing from. When we say an insult to medicine, it sounds a bit dramatic for just a cut, doesn't it? What exactly are we talking about here?
Yeah, it does sound a bit formal, maybe a bit harsh. But in medicine, insult is used really broadly. It's not just physical trauma like a cut or, a surgical incision.
Okay.
An insult can be anything that causes tissue damage. Think an infection, a burn, even toxins floating around in your bloodstream, maybe from an overdose of a common medication like paracetamol.
Right.
What's really crucial for you to grasp is that regardless of the specific injury or damage, the body kicks off a surprisingly similar set of repair processes. It has this kind of universal plan.
The universal plan. I like that.
And this basic plan is pretty straightforward. First, close the gap created by the injury. Second, repair it. Ideally, by restoring the normal tissue.
Back to how it was.
Exactly. If that's not fully possible, then the goal is to repair it with a scar. And the smaller and more functional that scar is, the better. It's like the body's prioritizing function and trying to minimize the evidence that anything even happened.
That broad definition of insult is really key, I think. It means this fundamental response system is way more universal than you might initially think for just like a simple cut.
Precisely.
Okay, so to make this whole process easier to remember, maybe for exams or just understanding it, we can think of the 5 essential stages involved in wound healing as an acronym. HIPRR.
HIPRR. Yep.
That stands for haemostasis, inflammation, proliferation, regeneration, repair. And critically, that final R is for remodeling. We're going to walk through each one of those stages.
That's good.
Let's dive into those first 2 immediate actions your body takes, starting with, well, the critical step of stopping any bleeding. H for hemostasis.
Absolutely. The very first H in our HIPRR is hemostasis. And this happens fast. We're talking seconds to minutes after an injury. Think of it as the body's rapid stop-the-bleed mechanism.
Emergency response.
Totally. These tiny disc-shaped cells, called platelets, they're the first responders, they rush to the injured site, stick to each other and the damaged tissue, and they actually change shape to form a temporary plug.
Wow.
Then they release chemical signals that call in more help and promote the formation of a strong fibrin clot. This fibrin clot acts like a natural mesh, sort of binding everything together to prevent more blood loss. And at the same time, the small arteries in the area constrict, they narrow to further reduce blood flow.
Okay, so bleeding stopped. What's next? The I.
Right, I for inflammation. This kicks in minutes to hours later and can last for days, or sometimes even longer if it becomes chronic, which is a whole other topic. But basically, this is your body's cleanup crew and defense team arriving at the scene.
Cleanup crew, I like that.
Yeah. Increased local blood flow floods the area, bringing essential oxygen, nutrients, and loads of immune cells. These cells then get to work using a process called phagocytosis, where they literally eat and engulf damaged and dead cells, bacteria, any debris that shouldn't be there.
So they're tidying up the site.
Exactly. It's a vital clearing out phase before the actual rebuilding can begin, making sure the construction site is clean and ready.
Okay, so the body has sealed the wound, cleaned house. What happens next? How does it actually start building new tissue? That brings us to P, proliferation. What does that phase really look like?
Right, proliferation. This is where the reconstruction truly begins, aiming for the regeneration of the damaged tissues. A key part of this phase is granulation tissue formation.
Granulation tissue.
Yeah, you could think of this as the body's initial sort of temporary scaffolding. a provisional matrix that fills the wound gap. And here's an anchor for you, something to remember. It have a granular appearance and texture. That's where it gets its name.
Ah, okay. Makes sense.
And for any medical students listening, a really crucial distinction here. This is not a granuloma. A granuloma is something quite different. It's the body's walled-off, specific immune response to a persistent irritant, like tuberculosis. Granulation tissue is healthy, temporary repair tissue. Very different things.
Got it. Not a granuloma. So what's in this granulation tissue?
It's rich in developing capillaries, like laying down new roads for supplies.
Angiogenesis.
Exactly. Angiogenesis is a big part of this proliferation phase. It also has fibroblasts and these special cells called myofibroblasts, plus some chronic inflammatory cells still hanging around. Its functions are vital. It fills the gap, the capillaries supply oxygen, nutrients, and cells, and it actually contracts, helping to close the hole.
And those myofibroblasts, you said they were special?
They are pretty remarkable. Think of them as microscopic zip ties.
Zip ties, okay.
Yeah, they grip the wound edge and actively contract, physically pulling the edges closer together, decreasing the size of the wound. And once their job is done, many of these cells, along with others that are no longer needed, undergo apoptosis.
Programmed cell death.
Exactly, a controlled, efficient exit, making sure no unnecessary cells linger. Meanwhile, the original cells that were there, like epithelial cells in a skin wound, are multiplying and growing across the wound bed, working to restore the surface.
Wow, that's a full-scale rebuilding effort. Really dynamic. Now, after all that construction, does our tissue truly go back to exactly how it was? Or is there, a permanent change? What decides if we get full regeneration or end up with a lasting scar? This brings us to the next R in HIPRR, regeneration or repair. And this links back to that question we posed right at the start.
Yes, this is a critical distinction, and it really gets to the heart of understanding healing outcomes. Whether you get complete regeneration or a scar, well, it truly depends on a couple of key things. The severity of that initial insult and the specific tissue's capacity for regeneration, which we'll get into more detail about soon.
Okay.
So when we talk about complete regeneration, sometimes called restitution, this is the body's reset button success story. The tissue returns to a pretty much near normal appearance and functional state.
Like it never happened.
Almost. This usually occurs with minor injuries, leaving no or maybe minimal evidence of the previous damage. A classic example is a superficial injury with closely aligned edges. Think a clean surgical cut that's stitched up well. That's what we call wound healing by primary intention.
Primary intention, got it.
Another fantastic example is the endometrium after menstruation. It completely regenerates every single month.
Amazing.
But for this complete regeneration to happen, several conditions need to be met. You need little to no interference, so no ongoing infection or repeated injury. The tissue damage can't be too extensive. You need an intact connective tissue scaffold for the new cells to build upon. And, importantly, the damage has to occur in what we call a labile or stable tissue type.
Labile or stable.
Yeah.
We'll come back to those terms, I assume.
We will, absolutely,
Right.
because the type of tissue is crucial. Now, with more severe injuries or where wound edges aren't nicely aligned, which we call wound healing by secondary intention, we often see incomplete regeneration. This results in fibrous repair, or basically a scar.
Secondary intention leads to scars more often.
Generally, yes. Here, the tissue doesn't return to its original structure. Instead, the gap is filled by that granulation tissue we talked about, which then matures into scar tissue. So, to finally answer your question from the beginning, the ability to achieve complete regeneration versus fibrous repair largely depends on three key things. 1, the type of tissue involved. 2, the extent of the injury. And 3, crucially, whether the underlying collagen framework is intact. If that framework is destroyed, or if the tissue is one of those permanent types, a scar is the much more likely outcome.
Okay, that makes sense. So the tissue type, the injury size, and the framework integrity determines scar or no scar.
Pretty much, yes.
So the body has either regenerated tissue perfectly or formed a scar. Is the job done then? What about that final R in HIPRR remodeling? How does the body refine or strengthen the repair over time? That seems important too.
Excellent question. Yes, remodeling is crucial and often gets overlooked. This is the body's long-term optimization phase. It's where the newly formed tissue, whether it's perfect regeneration or a scar, gets refined, strengthened, and organized. And this can go on for months, sometimes even years after the initial injury.
Months or years, wow.
Oh, yeah. For scars, it means the collagen fibers, which were initially laid down a bit haphazardly, are gradually reoriented along lines of stress. This makes the scar stronger, usually less bulky, and often less noticeable over time. It's about perfecting the repair, making it as functional and, well, inconspicuous as possible. Think of it as the body's quality control check and adding the finishing touches.
Quality control and finishing touches. I like that. Okay, you mentioned tissue types, labile, stable, permanent, influencing, regeneration. Let's dig into that classification. What exactly defines them?
Right, so not all tissues have the same ability to divide and repair themselves. We categorize them based on their normal proliferative activity using the LSP classification: labile, stable, and permanent.
LSP.
First, labile tissues. These are essentially continuously dividing tissues. They proliferate throughout life, constantly replacing cells that are lost or destroyed. Think of surface epithelia, like your skin, the lining of your gastrointestinal tract, or bone marrow cells. They're always turning over.
Constant renewal.
Exactly. Second, stable tissues. These are kind of quiescent but responsive. Normally, they have a low replication rate. They're just sitting there doing their job. But they can undergo rapid division in response to stimuli like an injury. Good examples are the liver, parenchymal liver cells, also bone, fibrous tissue, and the endothelium lining blood vessels.
So they can ramp up when needed.
Precisely. And finally, we have permanent tissues. These are the non-dividing tissues. The cells in these tissues have basically left the cell cycle permanently and cannot undergo mitotic division in adult life. This includes neural tissue, your brain cells, skeletal muscle, and cardiac muscle, your heart muscle.
Oh, so if they're damaged.
If they're damaged, they primarily heal with a scar. Or, in the central nervous system, the damaged area might get filled with glial cells, which are support cells, or even just become a space filled with cerebrochital fluid if the damage is extensive. They can't regenerate the original functional cells.
That LSP classification really clarifies why some tissues bounce back so well, like skin, and others, like heart muscle after a heart attack, end up scarred.
It's fundamental to understanding healing potential in different organs, absolutely.
And you mentioned earlier that ability to completely regenerate often depends on specific cells, architects of repair.
Ah, yes, the architects. These are our body's master builders, if you like.
Yeah.
Stem cells. These are undifferentiated cells that have this ongoing, prolonged ability to proliferate.
Master builders, okay.
What's really remarkable about them is their capacity for asymmetric replication. When a stem cell divides, one daughter cell remains a stem cell maintaining the pool, while the other one differentiates, it specializes, into a mature, non-dividing cell ready to perform a specific function. They act as this internal repair system.
Always keeping one back for the future. Clever.
Very clever biological design. Their location varies in the skin's epidermis, they're the basal layer, in the gut lining, down in the crypts, in the liver, sort of tucked between the main liver cells and bile ducts.
And there are different types of stem cells.
Yes, based on their potential, their flexibility. Unipotent stem cells, which are most adult stem cells, can only produce one type of differentiated cell, like skin epithelial cells. Multipotent ones can produce several related types. Think of hematopoietic stem cells in bone marrow, giving rise to all the different blood cells.
Okay.
Then you have pluripotent cells, like embryonic stem cells, which can theoretically produce any cell type in the body, any tissue. And even broader are totipotent cells, found only in the very early embryo, which can form not just all body tissues, but also the placenta and other extra embryonic structures.
Wow. That potential is incredible. Okay, let's switch gears slightly. When we talk about fibrous repair forming scars, there's one incredibly important player doing the heavy lifting for rebuilding strength: collagen. You mentioned its framework being key.
Absolutely central.
I think of it as the body's super strong internal scaffolding, kind of holding us all together.
That's a perfect analogy.
Yeah.
Collagen truly is the body's structural engineer. The source material we looked at described it beautifully using an analogy about Roman fascia.
Oh, yeah.
It said something like, a single thread is strong, the Roman fascia is stronger, and the intertwined helices of a rope are stronger still. It really highlights how collagen's unique triple helix structure gives it incredible tensile strength, resistance to pulling forces. It forms the extracellular framework for pretty much all multicellular organisms.
Holding everything together.
Literally, including the skeleton. There are many types, but type I is the most common. Think bones, tendons, ligaments, skin, blood vessels. Type I is crucial for basement membranes, the sheets that cells sit on.
And how is it made?
It's a complex process. Polypeptide chains, called alpha chains, are synthesized inside cells, mainly fibroblasts and those myofibroblasts we mentioned. Then there's a crucial step involving enzymatic modification, specifically vitamin C-dependent hydroxylation.
Ugh, vitamin C again.
Yes, it's absolutely essential for this step. Without enough vitamin C, this hydroxylation can't happen properly. These modified alpha chains then align and cross-link to form the procollagen triple helix structure. This structure then gets processed further outside the cell and matures into collagen fibers, which start providing that crucial strength to the healing wound.
Okay, so if collagen is this essential scaffolding and vitamin C is vital for building it, what happens if this structure isn't built correctly or if it breaks down?
That's a really critical question because defective collagen synthesis or problems with its structure can have profound effects, leading to a whole range of diseases. What these conditions really highlight is that collagen isn't just static scaffolding. It's dynamic, it's exquisitely structured, and its integrity is fundamental to almost every system in your body.
So problems here could be widespread.
Definitely. We see inherited conditions, for example, like Ehlers-Danlos syndrome, actually a group of related disorders. Here, there's often a defect in converting procollagen, meaning the final collagen fibers lack proper tensile strength. This leads to things like hyperextensible skin, very flexible joints, poor wound healing, easy bruising, and in some severe forms, even rupture of internal organs like the colon or major arteries.
Wow, that's serious.
Very. Another inherited one is osteogenesis imperfecta, often called brittle bone disease. Here you have defective or just insufficient type I collagen, leading to extreme skeletal fragility, frequent fractures, bone deformities. People with OI often also have blue sclerae. The whites of their eyes look blue because the thin sclera lets the underlying pigment show through, plus hearing impairment and dental problems.
So that's inherited. What about acquired problems?
The classic acquired example is scurvy, caused by vitamin C deficiency. As we said, without enough vitamin C, that crucial hydroxylation step is impaired. This leads to reduced cross-linking and defective helix formation in the collagen.
And the results?
Well, an inability to heal new wounds properly, a tendency to bleed easily, especially from the gums, tooth loss. But what's truly fascinating and directly answers your question about collagen breakdown is that in severe scurvy, old scars can actually break down and reopen as fresh wounds.
No way! Old stars.
Yes. It's a stark reminder that collagen isn't static. Even in a seemingly healed scar, there's ongoing turnover and remodeling. If the body can't synthesize new, stable collagen to replace the old, even established structures can fail. It highlights just how dynamic this scaffolding really is.
That's mind-bending, a healed wound reopening. It really makes you appreciate that even a fixed part of our body is still a living, working system, constantly maintaining itself.
Absolutely. Nothing is truly static.
Okay, we've seen the players, the plan, HIPRR, the materials like collagen, but how does the body know? How does it know when to start healing, how fast to go, and maybe most importantly, when to stop? It sounds like a complex, precisely orchestrated dance of communication.
It really is. And honestly, the exact control mechanisms for regeneration and repair are still, well, pretty complex and not fully understood in every detail. What we do know is that cells are constantly communicating with each other to produce that proliferative response when needed.
How do they talk to each other?
It can happen in several ways. Through hormones, which travel through the bloodstream and act at a distance that's endocrine signaling, or via local mediators like growth factors, which act on nearby cells, that's paracrine signaling, or sometimes even on the same cell that released them, which is autocrine signaling. It's like cells whispering to their neighbors or maybe sending themselves a quick reminder memo. There's also direct cell-to-cell contact, or cells interacting with the extracellular matrix around them.
And growth factors seem pretty important here.
Hugely important in wound healing. These growth factors are often called local hormones. They're typically polypeptides that bind to specific receptors on the cell surface. Binding triggers signals inside the cell, often leading to gene transcription changes that regulate the cell's entry into and passage through the cell cycle, basically telling it when to divide or what to do.
What kind of effects do they have?
Oh, a wide range. They stimulate proliferation, obviously getting cells to multiply. They promote mitogenesis, which is cell division, DNA synthesis, the crucial angiogenesis we talked about, building new blood vessels. They also influence cell movement, differentiation, specialization, tissue remodeling, and even chemotaxis, guiding cells to the right location, like drawing immune cells to the injury site.
Okay, so they're like the managers on the construction site, directing traffic and telling crews what to do.
That's a good way to think about it.
Yeah.
And interestingly, many of these growth factor genes are actually proto-oncogenes, genes that normally help control cell growth. But if they mutate, they can potentially contribute to cancer. It shows the fine line the body walks.
Right, controlling growth without letting it run wild. Is there a mechanism to stop the growth once the gap is filled?
Yes, another crucial control mechanism is contact inhibition. This is basically how cells sense their neighbors and know when to stop dividing because the space is full. It involves signaling through adhesion molecules, proteins like coherins that bind cells to each other, and integrins that bind cells to the extracellular matrix.
So when cells touch, they stop dividing.
In healthy tissue, yes, that's the general idea. This mechanism inhibits proliferation when a tissue is intact, but it actually promotes proliferation in damaged tissues to help close a gap. When the gap is closed and cells make contact again, the stop signal gets turned back on. It's a really neat system. And again, this process is often altered in malignant cells, which lose that contact inhibition, another link to cancer biology.
That tightrope walk between repair and uncontrolled growth is fascinating. Okay, let's bring it all together now by looking closely at those two main ways wounds heal you mentioned earlier, primary and secondary intention. You said we'd encounter these constantly in clinical practice.
Absolutely fundamental concepts. First, let's recap healing by primary intention. Think of this as the clean-cut scenario. It happens in wounds that are incised, closed neatly, non-infected, and often sutured, basically. Clean wounds where the edges are brought right together or opposed.
Like a surgical incision.
Exactly. There's minimal disruption of the underlying basement membrane and minimal cell death. Because the gap is so small, you get only a minimal clot and not much granulation tissue forming. The epidermis, the top layer, regenerates almost perfectly, while the deeper dermis undergoes some fibrous repair, but it's limited.
And the outcome.
Sutures might come out around 10 days, and although the wound is initially only about 10% of its normal strength, it heals with minimal contraction and minimal scarring. The end result is usually good strength and a fine line scar.
Okay, that's the ideal scenario. What about the other one?
Then there's healing by secondary intention. This is more like the open wound challenge. You see this in wounds where there's significant tissue loss, like a large scrape or the deep ulcer, or where the edges are far apart. Also common in infected wounds, infarcts, areas of tissue death due to lack of blood, and abscesses.
So, a bigger, messier problem.
Right. Here, the open wound has to be filled by abundant granulation tissue growing in from the edges. Because there's usually a larger clot, more dead tissue, maybe infection, the inflammatory reaction is much more intense and prolonged compared to primary intention.
And you mentioned contraction is key here.
Yes, a really significant characteristic is that considerable wound contraction has to happen to close the defect. Initially, the scab might contract a bit, but then after about a week, those amazing myofibroblasts appear in the granulation tissue. They actively contract, pulling the wound edges inward, sometimes dramatically reducing the size of the area that needs to be filled in.
Like a drawstring bag being pulled tight?
Exactly like that. But this process inevitably results in more substantial scar formation, and the new epidermis covering the scar is often thinner and less robust than normal skin. And, as you'd expect, healing by secondary intention takes significantly longer than primary intention.
Makes sense. Different approach for a different scale of problem. Now, what about bone? We talked about it being a stable tissue that can regenerate. How does it handle a break? Its repair must be quite specialized.
It is very specialized and quite remarkable. Bone can actually completely reconstitute itself after a fracture, essentially reactivating processes similar to those that happen during embryonic development. It heals in distinct stages.
Okay, what are they?
First, immediately after the fracture, you get a hematoma. A blood clot forms, fills the gap between the broken ends, and surrounds the injury site. This provides some initial stability and brings in inflammatory cells and signaling molecules.
Like haemostasis and inflammation in other tissues.
Similar principles, yes. Second, this hematoma is gradually replaced by granulation tissue. Cytokines, those signaling molecules, activate osteoprogenitor cells, cells that can become bone-forming cells.
Setting the stage for bone building.
Exactly. Third, by about 1 week or so, a soft callus forms. This is also called a procallus or fibrocartilaginous callus. It's made of fibrous tissue and cartilage, and within this soft scaffold, a temporary, less organized type of bone called woven bone starts to form. This creates a noticeable bulge around the fracture site.
A temporary patch.
Kinda, yeah. It bridges the gap. Fourth, appearing after several weeks, is the hard callus, or bony callus. Here, specialized cells called osteoblasts lay down more woven bone, making the callus much stronger and more rigid.
Getting more solid.
Definitely. Fifth, the woven bone, which forms quickly but isn't super strong or organized, is gradually replaced by lamellar bone. This is the mature, organized, and much stronger type of bone that makes up our normal skeleton.
Replacing the temporary fix with the permanent structure.
Precisely. And the final crucial stage is remodeling. This can take months or even years. The bone is gradually reshaped in response to the mechanical stresses placed upon it. Osteoclasts, bone-resorting cells, remove bone from areas that aren't stressed, while osteoblasts lay down new bone where it's needed. In ideal circumstances, the bone's original outline and strength are fully reestablished.
It really is a masterclass in regeneration. But, as we know, healing isn't always smooth sailing. What kinds of things can throw a wrench in the works? What factors can impede this whole amazing process and lead to complications?
Unfortunately, yeah, many factors can hinder healing. We can group them into local factors, right at the wound site, and general factors related to the patient's overall health.
Okay, let's start locally.
Local factors include things like the type, size, and location of the wound itself. Some areas just heal better than others. Mechanical stress is a big one. If a wound is constantly being pulled or stretched, it struggles to close. Blood supply is absolutely critical. Poor circulation, maybe due to arteriosclerosis, severely impedes healing. Ischemia, lack of oxygen, is related to that.
Infection must be a major issue locally.
Huge issue. Local infection causes persistent injury, prolonged inflammation, and prevents proper repair. Swelling, edema, dead tissue, necrosis, or having foreign bodies like dirt or stitches left in too long can also interfere. And of course, repeated or ongoing injury to the same spot is problematic. On the flip side, good surgical technique, handling tissues gently, ensuring good blood supply, closing wounds properly actively promotes healing.
Right, and the general factors.
Yeah.
Affecting the whole person.
General factors are numerous too. Age is significant. Children generally heal faster and better than the elderly. Conditions that affect oxygen delivery, like anemia, hypoxia, or hypovolemia, low blood volume, are detrimental. Obesity can be an issue. It increases tension on wounds, especially abdominal ones, making them more likely to split open dehiscence, and fatty tissue has poorer blood supply.
What about chronic diseases?
Diabetes is a major one. It often causes microangiopathy, damaging small blood vessels and impairing circulation, plus it decreases resistance to infection. Malnutrition is another big factor. If you lack essential building blocks like amino acids from protein, you can't synthesize collagen and other necessary components effectively. Genetic connective tissue disorders, like the Ehlers-Danlos we mentioned, obviously impact healing.
And medications or lifestyle?
Certain drugs can interfere. Steroids, like corticosteroids, are well known to inhibit inflammation and collagen synthesis, slowing healing. Cytotoxic drugs used in chemotherapy impair cell proliferation across the board. Cigarette smoking constricts blood vessels and reduces oxygen delivery. Vitamin deficiencies, especially vitamin C or collagen, are critical. And anything causing immunodeficiency makes infection more likely and hinders the inflammatory response. Even malignancy elsewhere in the body can cause cachexia, a wasting state that impairs healing.
Wow, it's a long list. So many things can go wrong. And when fibrous repair does happen, even if it's necessary, you mentioned it can have its own complications too.
Yes, scar tissue, while essential for patching things up sometimes, isn't perfect. You can have insufficient fibrosis, leading to problems like wound dehiscence, where a surgical wound opens up, or the formation of a hernia, where internal tissues bulge through a weak spot, or chronic ulceration, where a wound fails to fully heal.
So not enough scar.
Right. Or you can get problems from the scar itself. Formation of adhesions is common, especially after abdominal surgery. These are bands of scar tissue that can form between organs or tissues that aren't normally connected, potentially kinking tubes like the intestine and causing obstruction.
That sounds painful and dangerous.
It can be very serious. Another major issue is loss of function. This happens when specialized functional cells, like heart muscle cells after a heart attack or liver cells in cirrhosis, are replaced by non-functional, non-contracting scar tissue. The organ might be structurally intact, but it can't do its job properly.
The patch isn't the same as the original fabric?
Exactly. Scar tissue can also cause architectural distortion, disrupting the complex tissue relationships needed for normal function, like in liver cirrhosis, where scarring distorts the liver structure and blood flow. Sometimes you get overproduction of fibrous scar tissue. The classic example is a keloid scar, which is this big, raised, often itchy scar where collagen production goes into overdrive and grows beyond the original wound borders. It's more common in people with darker skin, particularly those of Afro-Caribbean descent.
Keloids, right. I've heard of those.
And finally, excessive scar contraction can be a huge problem. While some contraction helps close wounds, especially secondary intention, too much can cause issues like stenosis, a narrowing of a tube or passageway, like in the esophagus, intestines, or urinary tract after injury or inflammation. It can also lead to severely disfiguring scars, especially after extensive burns or joint contractures, where a limb gets stuck in a bent position due to the scar tissue tightening across the joint.
So scar tissue is a necessary evil sometimes, but it comes with its own potential downsides.
A very good way to put it. It's often the best the body can do in difficult circumstances, but it's rarely a perfect replacement.
Okay, just briefly before we wrap up, could you touch on how a few other specific tissues handle repair? We mentioned heart and bone, but what about, say, nerves or cartilage?
Sure, it highlights the diversity again. Cardiac muscle, as we said, part of the permanent tissues group, has very limited regeneration capacity. A myocardial infarction, a heart attack, leads primarily to scar formation, which can impair the heart's pumping ability.
So the damage is lasting.
Largely, yes. Cartilage, the stuff in your joints and nose, heals very poorly. This is mainly because it lacks its own blood supply, lymphatic drainage, or nerves, all things that are usually critical for bringing in repair cells and nutrients. Injuries often lead to degeneration over time, like in osteoarthritis.
That explains why cartilage injuries are so tricky.
They really are. The liver, though, is the opposite extreme. It's a stable tissue, but has remarkable regenerative capacity. If a significant portion is removed, say surgically or lost to injury, the remaining liver cells undergo compensatory growth, replicating until the original mass is pretty much restored.
Wow. The liver can bounce back.
Amazingly well. Now, neural tissue is complex. In the peripheral nervous system, nerves outside the brain and spinal cord, if a nerve fiber axon is cut, but the cell body survives, the part distal to the cut degenerates, but the proximal stump can actually sprout new extensions. These sprouts can be guided by Schwann cells, support cells in peripheral nerves, back towards their target, growing about 1 to 3 millimeters per day. So some recovery is possible.
Slow, but possible.
Slow and often incomplete, but possible. However, if the nerve cell body itself dies, the whole neuron is lost permanently. In the central nervous system, CNS, the brain and spinal cord, it's different. CNS neurons are permanent tissue. Damage typically leads to a replacement by glial cells, support cells like astrocytes, forming a glial scar, or if the damage is very large, maybe just a fluid-filled space. There's very little functional regeneration of neurons themselves in the CNS.
So brain and spinal cord injuries are generally permanent.
In terms of neuron replacement, largely yes, though there's intense research into changing that. And one other interesting point about nerve repair, even when peripheral nerves regenerate or remyelinate, rebuild their insulating sheath, like after diseases like MS go into remission, the new myelin segments are often shorter and thinner than the originals. Function might recover, but structurally it's not quite back to baseline.
That's fascinating detail. Okay, wow. We have covered a lot today, from the body's initial sort of battle plan, that HIPRR framework, haemostasis, inflammation, proliferation, regeneration, repair, and remodeling,
Yep, the whole sequence.
to the intricate dance of cells like stem cells and myofibroblasts, molecules like collagen and growth factors, and the really incredible complexity of how healing happens, or sometimes, unfortunately, how it goes wrong. It truly is a marvel of biology.
It really is.
Yeah.
And, for anyone listening who's studying medicine, understanding these fundamental processes isn't just about memorizing stages for an exam.
Yeah.
It's really about seeing the incredible resilience of the human body, but also recognizing when and why that resilience is challenged.
Yeah.
This knowledge is truly your foundation for understanding pathology, for diagnosing conditions, for figuring out why a wound isn't healing, and eventually for developing effective treatment strategies in your future career. It shows you why, a simple cut is rarely simple at the cellular level, and why some injuries leave a lifelong mark while others seem to just vanish.
Absolutely. So here's a final thought for you, our listener, to ponder. Given how exquisitely coordinated this healing process is, and yet how many factors can influence it or complicate it, what advancements in medicine do you think hold the most promise for actually enhancing regeneration and maybe minimizing scarring, particularly in those tricky permanent tissues like the brain or the heart that struggle so much to rebuild themselves? Something to think about as you continue your own deep dive into the amazing human body.